Development Seminar. I'm really happy to have Dr. Cameron Gaskill here today, and I'll make a very brief introduction and then we can get started. Typically, I think we go for about 40 to 45 minutes and then we'll leave room for questions. Um, so let me see here. I got a brief intro from Julie. So Dr. Cameron Gaskill is a hepatobiliary surgical oncologist and the director of the Center for Global Surgery at UC Davis. He completed a Fogarty Fellowship in Ghana and now serves on the Global GloCal Steering Committee. Really appreciate your contribution to serving on our committee. His work focuses on increasing surgical and cancer care capacity in LMICs through education, research, and international advocacy. So I'm really happy to have him here, and I'll turn it over to uh, Dr. Gaskell. And I think you can use the chat function to like type in any questions as he's presenting, and then we can also wait till the end to ask questions. So welcome, and I'll turn it over to you.
Thank you. Yeah, I don't know if the chats are going to pop up on my screen, but if I'll
No
try and
worries.
if they
Yeah,
do.
yeah. I'll just monitor. So,
Okay, perfect. So, welcome everybody. I remember being in your shoes and trying to find internet at like 4 p.m. in Ghana for these meetings so that I could so that we could listen to these talks. So, thanks for the introduction. Yeah, I'm a surgical oncologist at UC Davis. I'm also the director of the Center for Global Surgery, and I was asked to kind of go through my career trajectory and give some kind of tips for those of you who are trying to develop a career in global health. So I'll start off with a few caveats. One is I feel like I've been extremely lucky in my career, so I don't know if this is like a normal thing for most people to get to do. And then two is I talk to a lot of people about global health careers. So if you have any questions, any even down to you want me to review your contract as you're looking at a job, or you want some advice on where to go or what to look at or what to get involved in, by all means, I'm happy to talk. And my email's listed on this slide and on the end slide. So what we'll do, brief outline is we'll go through, actually I should start with this. So it was during my time in Ghana. You can see the Ghanaian flag there. And I use this slide a lot because, global surgery in general has been, described as the forgotten stepchild of global health. And for a long time, we've been kind of mirrored in describing problems, but not necessarily trying to fix them. And so this I don't know more kind of signifies that my ethos of global surgery research is really that we need to start changing things rather than just watching them. So this is our outline for today. I'm going to go over my background, career path. I'm going to give you a brief taster on global surgery and global oncology. I'm going to talk about my work here at UC Davis and then talk about kind of some lessons learned along the way and open it up for more of a discussion where you can, ask some questions. This was the, picture of the OR in Kumasi where I was working. The sign kept falling down. So my background, I grew up in a very small town. This is actually, it's rural Washington State. This is my front yard. It's out in the kind of the peninsula island regions of near Seattle. And so, I went through school fine. I was actually the first. My school was very small, like 2,000 people in my town. So I was the first person to be a doctor out of my high school. And actually, it wasn't even a high school, it was a secondary school. So we had, 7 through 12 in one school. Um, I went to college in Seattle at University of Washington. And when I got there, I didn't really know what I was doing. I kind of wandered around. At one point, I thought I was going to just play lacrosse for my whole life. And my mom told me to go get a job. So I went and I actually interviewed at a bunch of different labs and was accepted at a lab doing neuroscience, looking at salt and thirst appetite. And the job that they needed me to fill was putting these little catheters up on the upper left of your screen, putting these little catheters into the femoral artery and femoral veins of mice. And so that we could inject high hypertonic saline and measure what that does to their brains later on. And that was it for me. I caught the bug. I loved surgery. I decided that's kind of what I wanted to do with my life. And I started doing more and more animal surgery. I was working in labs and I started working for the University of Washington Bioengineering Department. And I I was designing like mouse models for different disease types. I ended up getting summer jobs at this emergency center. You can see how small of a town I live in because there's no area code on the phone number. Um, and that was that. At the same time, I was studying anthropology. So I was under the instruction of this guy, Dr. Speed, who had been working in Sierra Leone for years and years and years, studying witchcraft and religion. And then, as most of you will know, the Sierra Leone Civil War broke out. It was between 91 and 2002, and then the UN mission in Sierra Leone continued until about 2005, and they pulled out in December 2005, and we went that next summer. And so he was going back to restart his research, and he invited me along. And so I was at the time majoring in medical anthropology, and so went with him up to this small town, Cagberry, which is in the north. It's about 6 or so hours north of McKinney, which is the third largest town in Sierra Leone. And we did a lot of work on medical anthropology. And so the picture, this is the village we lived in. This is Clark Speed and one of our friends. And these are some herbs that we're using for medicines. This is a bone setter making a splint. Um, all really interesting stuff. And I kind of, while I was deciding I wanted to do surgery and learning this, slowly drifted my way towards McKinney and started working more in the clinics and working more in the hospital. And so the next few years I spent in McKinney working at the McKinney General Hospital. I was a researcher there and I was implementing the WHO surgical safety checklist. So many of you will know the name Atul Gawande. He had just published, him and Tom Weiser, who's actually a resident at UC Davis, well before I came here, and then him and I crossed paths in Seattle, as when he was doing his fellowship. Published the paper on the WHO surgical safety checklist. It's kind of this pivotal landmark paper in surgery, in global surgery, where we could start to fix the problems we were seeing. And so this is my team at McKinney General Hospital. We did a lot of work there, and then after that, I applied and got into medical school. So I went to medical school at the University of Washington. I continued on at the University of Washington for general surgery residency, and in between took 2 years of research. My first year of research, I got my master's in public health, and I worked at an outcomes research laboratory. So really using big databases. But my interest was obviously like disparity medicine and global health. So I skewed that towards kind of learning how to do biostatistics and how to really leverage my experience with my MPH so that I could help to do research kind of more independently. So the next year, I got to do my Fogarty Fellowship, and so I was a part of the Global Health Fellows, Northern Pacific Global Health Research Consortium. It's like Seattle and I think Michigan and a few others. I was in Kumasi, Ghana for those years. The picture down here is Adam Jidu, who's my kind of counterpart the whole year, and he was great. We did a lot of research together. Interestingly, my project was really more trauma surgery related. So we were looking at diagnosing HIV in the trauma patient population because we had some preliminary data that suggested that maybe HIV positive patients were higher utilizers of the ER, and this would be a good place to kind of be able to make contact with them and get them on the appropriate antiretrovirals. That project didn't pan out so great, but I did a lot of other research, uh, and we published a lot. And so a lot of the work we did was looking at just surgical capacity and then surgical unmet need. And so we published multiple papers around this idea that was based on the Lancet Commission. So the Lancet Commission in Global Health was this big paper that came out in, I think, 2015 and really gave 6 key metrics for how to judge a surgical system's strength. You can read through these. So, access to surgical care or timely access to surgical care, adequate workforce, a volume of surgery, which we spent a lot of time doing. We looked at, perioperative mortality rates and then the financial impact of surgery. So there's good data to show that surgery improves the GDP of a country because you improve you lessen the Dali's loss or you keep your workforce healthy and they're able to contribute back to the economy. There's also surgery is very expensive, so if you use too much surgery or you don't mitigate the costs of surgery, it can put people into financial catastrophe relatively quickly. So we kind of focused in on this surgical volume thing. There was some data kind of extrapolated from some like really good health systems. So I think we call it the four C's is Cuba, Costa Rica, China, and Chile, I think. And those were health systems that were public health systems that got kind of the best outcomes for the least amount of cost. So these kind of model ideal good value systems. And so you can see back in a lot of these papers, the big one was this national enumeration of operations performed in Ghana. So Adam and Barkley, who's the Fogarty Fellow before me, had gone through the country and they enumerated every surgical procedure that was done in the country. And we went back and started breaking those down by type of surgery, by indication, all that by population to really look at who was getting surgery and who wasn't, what needs were being met, what needs weren't being met. One of the projects that I kind of spearheaded was the one around cancer surgery. Now, cancer surgery is really complex, and obviously, you look at or look at rectal cancer, for instance. We're not operating on rectal cancer anymore because we have radiation therapy that's getting some, complete pathologic responses. And so you could look at a system that maybe they're doing more cancer surgery for rectal surgery, but that might be inappropriately high versus, pancreas surgery where we may be doing too few surgeries, and that would indicate that we're not finding these diagnoses early enough. We're not offering surgery in a timely fashion. So that benchmark isn't, are you above it or below it, but more are you at it? And so we did this with cancer surgeries and found that, there's a total of just over 2,000 procedures per 100,000 cancer cases. We then compared them to another model system in New Zealand where they were doing about 10,000 cases per 100,000. And we did this in a pretty clever way where the Ministry of Health in New Zealand gave us all their data. And so we had all the GDP or all the global disease burden incidence rates of cancer for the year. We had how many procedures were being done for those incidence rates. And so we could really try and compare apples to apples. Ultimately, what we found was Ghana was meeting about 21% of their estimated need for cancer operations, but it was only 0.7% of their total national operative volume. And we found that, with cancer being the fourth leading cause of death and seventh worst loss of dollars in the country, that was probably insufficient. In fact, there were more surgeries being done for hernias, for trauma, for OB-GYN, for pediatrics, and for the elderly outside of cancer in each of those individual categories than there was being done for cancer. So it was really, it kind of highlighted the unmet need. The other thing we did was we compiled a giant database on cancer surgery outcomes. And so what we found was that for one, not a lot of curative operations are being done for the more intense cancers, hepatobiliary, foregut, um, and even within breast and colorectal, a large proportion of palliative surgeries were being performed. Now this kind of skews things. What we did is we went through each of these operations. We talked to the surgeon. We asked them, was that operation intended to be curative or was that operation a palliative procedure? And so that's how we qualified these. And then we started doing some survival metrics on it. What we found was while curative operations had a survival where those patients survived longer at 3 years, it wasn't statistically significant. One could say maybe the numbers weren't enough to really drive that data. But what it kind of showed us is that even for the patients that we think we're trying to provide curative resection for, we're falling a bit short. Now, that was kind of the start of my interest in cancer, to be honest. And so we published these papers in Ghana around cancer care, and it really focused my idea that, cancer is becoming a big thing in lower resource areas. The global disease burden is shifting away from things like, infectious disease and even trauma. And so that became kind of my passion, my focus is this intersection between global disparities, cancer, and surgery. So just to briefly go through a brief introduction to global oncology, you know that surgery is a big problem, or access to surgery in LMICs can be an issue. The last estimates are that, greater than 70% of the world's population don't have access to timely, safe, and affordable surgical care, and that's over now 6 billion people. This is kind of the map of surgical disparities. You can see like the big red zones. So, Southeast Asia, Sub-Saharan Africa, parts of Central and South America. And when you look at the global disease burden, surgery plays a kind of a pivotal role in this. So it's not just health, it's not just surgical disease, but it's the health of the whole system. Uh, Surgery, this is a graph of what surgery, the proportion of each diagnosis that needs an operation. Okay. So you can see, obviously maternal disorders, we need C-sections, we need, uterine rupture, we need, these different problems that can occur during pregnancy, and those need surgery. HIV, AIDS, and tuberculosis, they get Kaposi sarcoma. There's different things that they may need that require surgery. So lesser. You see down at the bottom, transport injuries. Yeah, a high proportion of those need surgery. In the non-communicable diseases, however, you see neoplasm is the second highest, right below musculoskeletal, which I've kind of covered up with this box. So, just to push the point that surgery is really important to cancer care, and when cancer is increasing in these areas, it's something we really need to think about. So this is a graph. I just pulled this off. So it's the 2002 data for uh, incidence of or sorry, mortality of cancer worldwide. And again, just like you saw the disparity of cancer care, or sorry, surgical care, the hot spots are in sub-Saharan Africa, South America, Southeast Asia. Now, this is a study that a friend of mine did that I'll actually show his picture later. That they went through and they looked at the global disease burden of neoplasms for each country and then estimated whether or not they had adequate surgical capacity. And so this became kind of a metric of cancer surgery capacity. And again, you see the hotspots are the same places, Southeast Asia and Sub-Saharan Africa mostly. Um, This is that data in another way. So looking at this graph to the right or sorry, the table to the right first by WHO region, this is cancer procedure per surgeon ratio. And you see that, surgeons in Africa are having to do a lot more cancer surgeries than typical. Same thing in Southeast Asia, same thing in the Western Pacific. And that's both a number of, there's a lot of cancer procedures that are needed, and there's also just not a lot of cancer surgeons. On the left hand, this was done by the disease control priorities that looked at just the number of surgeons and anesthesiologists in operating rooms in high income countries versus low income countries. And you see that there's tenfold the amount of resources in these high income countries. Sure, none of this is surprising to you guys. Nope. Sorry, it's making me log in also. Um, And then, understandably, looking at complications following cancer surgery, there's also a trend that it's tougher in low resource areas. So this is looking at three different cancer types: breast cancer, colorectal cancer, and gastric cancer. You see that 30-day mortality and major complication, 30-day mortality is at the top, major complication at the bottom. You see a nice steady graph, especially for colorectal cancer and gastric cancer, that income group affects the outcome. So after my Fogarty Fellowship, I went back to my 2 years of residency, really dove into hepatobiliary surgery and found kind of, was able to successfully or, reasonably match my interest in cancer surgery disparities and global surgery to a clinical interest in hepatobiliary cancer surgery, and ended up going to fellowship at MD Anderson. So MD Anderson was, great, amazing training. Unfortunately, when I got there, COVID hit. And so all the global surgery stuff that we had planned for my 2 years kind of was put on hold. The three people to the right here are three pretty influential people in global oncology. So Kathleen Schmieler's at the top. She's a gyn-onc. She does a lot of work with cervical cancer in Mozambique. She's kind of heading the whole global oncology platform at MD Anderson, and she was my advisor for the 2 years. Nabil's in the middle. So Nabil did that project on looking at the cancer surgery capacity worldwide. He's originally from Pakistan. He came to the U.S. To do his medical training, and now he's at the University of Wisconsin as I think the head of their global or high in their global surgery department. Him and I worked very closely together on a lot of projects and continue to collaborate. And then down here is Dasha. So she's a medical oncologist. Her and I worked really closely building out the global oncology kind of interest group and then making it a subcommittee within the House Staff Senate at MD Anderson and building out a few different things, including a a global oncology tract for residents and fellows, and also like an interest group. We did a grand rounds that's still going, and really kind of built out the infrastructure so that people interested in global oncology who are at MD Anderson had a way to kind of plug in. And so her and I continue to work on projects both in the Ukraine, where she's originally from, and in Cote d'Ivoire. Looking at, oh, she's a breast surgeon or breast medical oncologist, so a lot of breast surgery things, but also a lot of gastric surgery. So then, as I was looking for jobs, again, it was COVID, so we didn't interview at a huge amount of places, but I was interested in getting an academic job that focused on global oncology or global surgery. And, those jobs can be tough to find. I was lucky enough to get an interview at UC Davis. Dr. Farmer, who's my chair, has had a longstanding interest and activity in global surgery, and she was really looking for someone to reinvigorate the global surgery program at UC Davis. Now, we'll talk about this a little bit later, where you kind of have to decide whether you want to try and plug into a system that's already got a huge global component, or if you want to try and build your own. And so I was interested in building my own, and UC Davis had very fertile grounds to do this and a lot of support, and it had global surgery activities in the past that I could plug into, but also had the benefit of being part of the UC system, which for those of you who don't know is I think like 10 schools. They have a whole UC Global Health Institute, which the GloCal Fogarty is under, and there's multiple people at every institution working on different things. So for me, it was an option to not only have like an area that I could build my own program, but also have ready-made collaborators nearby. And so for me at UCSF, there's the Global Cancer Program that Catherine Van Loon runs. There's the CHESA program, which is with surgical anesthesia care that is run by Dr. Osgadies. And so I was able to have some, collaboration and mentorship kind of right out of the gate, which I thought was really important. And then the other thing is having a Fogarty program. So, I recognized the importance of my Fogarty training and wanted to be, part of that now. So when I joined faculty here, I was put on the UC Davis or sorry, the GloCal steering committee, and was able to interact with that, and lo and behold, we have Janine, who's I think my second Fogarty fellow, to help train this next generation. Um, so we've built the UC Davis Center for Global Surgery over the last 4 years or so, and I'll admit it's very skewed towards my interest because while there are people who like to do global surgery here, it's not much of an academic endeavor for most people. Don't have that luxury of time and the funds to dedicate to it. So most of our projects have been really focused on cancer care. So the big projects that we have going on are in Tanzania with liver cancer care and kind of surgical oncology training. Well, I'll briefly touch on those later. Thailand with financial toxicity of cancer surgery. We have budding projects in the Gambia looking at liver cancer epidemiology and surgical training. Honduras, South Africa, Cote d'Ivoire, Ukraine, multiple other places. And we'll talk about kind of how I I've decided, how we've built that, how we've made our priorities, and how you can get these kind of types of projects running for yourself later on. The big one that I'm really passionate about is the increasing liver cancer capacity in Tanzania. I saw Nashi just joined, so Nashi is another colleague of ours working in Tanzania. Liver cancer was identified as a priority for Tanzania. It's the second leading cause of cancer-related mortality in sub-Saharan Africa. Working closely with the team you see in the image here. This is one of the tumor boards run by Dr. Mwanga and Dr. Eric, who are really heading the charge on building liver cancer capacity and kind of organizing the system around it. They've established this National Cancer Tumor Board that's now being supported by a CRCC grant, which is a California Cancer Research Grant, to expand nationally. They had held the initial Tanzania Liver Cancer Conference, which was like a 2-day event where there were a lot of Tanzanians talking about liver cancer in their country and spanning the gauntlet, not just the surgical treatment, but the IR treatment, the medical oncology treatment, even the early diagnosis, the hepatology, the looking at how to tackle hepatitis B, the multidisciplinary group. We were able to invite a bunch of international experts to give talks, which I think was really great and really kind of invigorate the group about tackling liver cancer in Tanzania. We're now going to hold that second Tanzania Liver Conference later in, I think, July now, which should be a good event. We've also worked on, building a research platform. So looking at the epidemiology and the outcomes of cancer research, we have a pending KO1 right now that was submitted that, hopefully cross our fingers, depending on how things go with global funding in this country. We have a few other research grants pending, but all to support this idea of building out liver cancer capacity. And so that brings me to Janine, who's one of your cohort. She's doing a project specifically looking at the prehabilitation of liver surgery patients. And so I'm sure as you guys know, performance status is a big problem in liver cancer. It's actually part of our staging algorithm with the Barcelona Clinic liver criteria. And patients often present with cirrhosis and deconditioned to the point that they can't get surgery or other treatments. And so there's some good data in the US and some other high-income countries, and even some middle-income countries and places like China, that you can put patients on a rehab program, we call it a prehab program because it's before surgery, and improve their performance status so that they can then be candidates for more treatment. And so we're piloting this idea in Tanzania, and I won't talk about the results. I'll leave that to Janine. But this is an example of just one of the many projects we're trying to launch to improve care for liver cancer patients everywhere. The other project and actually the reason that I was even introduced to these collaborators in Tanzania is this surgical oncology curriculum. So this is Dr. Godfrey in the top corner. He has a Surgo grant looking at building out a curriculum for surgical oncology. So, surgical oncology is becoming more and more a big part of general surgery. The training for that can be mired by the lack of procedures and lack of skilled mentors in it. And so he's built out a lab and a curriculum that hopefully will be launching soon. It's been a little delayed to help teach residents kind of specifics about certain technical aspects of cancer surgery. And so we've built this curriculum. I think the video up here, these are Nashi's hands showing us the expert way to tie some knots on anastomosis. This is a team working on doing anastomosis with a model that Nathan Brand, the Fogarty last year created between I think it's a chicken esophagus and a chicken trachea for a vascular surgery. And then this is our global rating scale. So the idea is that we put residents through this curriculum. We grade them before and after. We see how they're improving. We look at the needs of the residents' training and try to adjust our curriculum accordingly. The other, in line with this is the liver surgery curriculum. So we've created a model using a cow liver. So we go to the slaughterhouse. Our research assistant Weibo has made good inroads with them, and they've trained the folks at the slaughterhouse to harvest livers, and we're able to perfuse them with catheters to simulate CVP, which is central venous pressure and portal venous pressure, and also arterial pressure, so that we can create a kind of low fidelity, very realistic model for people to practice liver surgery. Liver surgery, I mean, I'm not just saying this because I'm a liver surgeon. Liver surgery is very technically demanding. And so any practice you can get before the real thing can be really helpful. We're hoping to, we're actually in the middle of a program right now where we're having, again, international experts give weekly didactic lectures to a group of early faculty and fellows at Muhimbili in Tanzania on liver surgery. And then in 2 weeks, we'll be doing a hands-on liver lab with 10 trainees and doing, again, pre and post test competency testing, looking at things like blood loss, looking at things like knowledge of liver anatomy and ability to transect along the right lines. All these things with the idea that we're creating a curriculum that can be deployed across areas of low resource settings so that we can improve liver surgery outcomes. And the final thing that we're really passionate about in Tanzania is creating a research platform. So, uh, Dr. Mwanga has created the Tanzania Surgical Research Group. It meets monthly with kind of works in progress meetings, and it's meant to mentor surgical trainees towards a better understanding of how to do research. And the goal of preparing them for things like GloCal and the UCSF Global Cancer Program D43 and other bigger research training programs that are around. Uh, Surgery, the Department of Surgery has had a lot of recent interest in building their research platform. I think partly because of people like Nashi and people like Mwanga who are kind of leading that charge. Dr. Mwanga is the head of the department. He's now made a mandate for residents to publish before they graduate. So really supporting this research effort, which is really necessary for us to kind of turn the tide on a lot of these diseases because there's just not a lot known and there's not a lot published. And so this is like a highlight for me getting to work with these trainees in at Muhimbili who are also passionate and like interested and smart and dedicated and all the things that you hope to find in people you're working with. So that's Tanzania. The other slides will be a little quicker. So in Thailand, Jade So, who's becoming a fourth year medical student at UC Davis, is working on a project supported by UC Davis Center for Global Surgery, and she's also a Harvard medical student. Paul Farmer Program fellow, looking at the quantitative and qualitative impacts of cancer surgery on patients' finances. So she's looked at financial toxicity in a lot of different ways. They're looking at it over a variety of cancer types. And finding that, as you'd expect, financial toxicity is pretty rampant even in Thailand, where a lot of folks have universal health coverage. She's looking at not just the cost of surgery, like the dollar, the bill from the hospital, but also the indirect costs, such as, having to take time off work, having your family members take time off work to take care of you, having to travel, having to relocate to maybe the bigger city for your cancer operation, the cost of complications, all of that kind of a big global picture to try and find areas that we can improve the financial burden of surgery on these patients. And so she's done a lot of work this year. She's just finishing up. I think they've enrolled a total of like 200 patients. And the last couple months have skewed towards the things that, again, I'm more interested in: liver, pancreas, stomach, cholangiocarcinoma, those bigger operations. And I'm excited to see kind of what we can find out of how we can potentially reduce the cost for these patients. They're also in the middle of the qualitative review. So they've done 15 or 20 interviews now with different patients, looking at ways that they are impacted from a financial perspective with their care, but also solutions from those patients that we may be able to adopt. And the next area we'll talk about is this is the Gambia. So Dr. Lamin is from the Gambia. He just finished his training in Mumbai, and he's now the first surgical oncologist in the Gambia. He actually trained in the same place where Nashi's mentor trained, and then he just got the International Surgery and Travel Exchange SSAT award, which Nashi got last year. So we're like building a pipeline of people through these programs, which is really great. So I was introduced to Lamin through Dr. Macbeth, who's one of the ER doctors at UC Davis, who has a longstanding relationship in the Gambia doing point of care ultrasound, and Dr. Maud, who's an IR doctor who has kind of joined that group. And the idea being they're using point of care ultrasound to kind of avoid needing higher imaging like CTs and MRIs. And then Maud's able to come in and actually do interventions. So, they're finding abscesses and they're able to, liver abscesses, for instance, and able to drain that percutaneously rather than needing to do a surgery. Now, I was brought into the collaboration because Lamin is a surgical oncologist, and so he wants to work with surgeons. And so now we're working on a few things looking at, again, hepatocellular carcinoma in the Gambia. We're at the benefit that the Gambies had a long-standing relationship with places in the UK, and they've done a lot of gastroenterology and hepatology work in like hepatitis B and risk factors for hepatocellular carcinoma. So we're kind of building off of their platform, looking at the unmet need of surgery and the impact of introducing new technology like ablation or TACE or surgery or even immunotherapy, how that would impact the country, what the priority should be in terms of care, knowing that, most patients present late. So maybe, what we're finding is maybe immunotherapy would be more helpful than surgery initially, but trying to tease those nuances out. So that's those are kind of the three big projects that I'd like to talk about that we've built here. We've also built a lot of one-off things. We've done work in Central America looking at gastric cancer screening. We've done work in Ukraine looking at surgical outcomes. A lot of these projects have been kind of people coming and saying, "Hey, we have this idea. We're looking for someone in the U.S. to partner with. Do you know anybody?" And I think, as we talk about lessons learned, that's kind of the biggest thing that I can walk away with is, finding a good fit. I was introduced to the group in Tanzania by some medical oncologists working there, and I met some great people and made good relationships with Nashi and with Dr. Mwanga and good friendships that I think really are the backbone of those collaborations. Similarly, I've had a lot of conversation, or sorry, in contrast to, I've had a lot of conversations with different groups who have a good idea and interest, but it's not necessarily a perfect fit for us, right? Like I do cancer surgery, and that's kind of my expertise. I don't know a lot about trauma registries, for instance. And so when a country or an individual comes to UC Davis asking about that, it's not necessarily the perfect fit. So I try to redirect them. And, again, one of the great things about being in the UC system is I can redirect them to, Dr. Juilliard down at UCLA, who does trauma systems, or Teresa Chen down at UCI, who's a trauma surgeon. And they're like, they can embrace that, right? Pediatrics, right? I'm not a pediatric surgeon, although we try to operate on pediatric livers as much as we can. But when there's big pediatric projects, we have, Daruk Osgoodies at UCSF who can kind of take the reins and help in a much more meaningful way than I can, and, potentially a much better fit than I would be. So, um, I think I want to give, like, since I'm still pretty junior, some ideas about kind of getting higher and jobs and that negotiation contract. I want this to be interactive, so if you guys have questions, please pipe up and let's talk about it. What I found was, as I was going through both fellowship interviews and job interviews, I kind of everything broke down into thirds. There were a third of people who thought that this was the best idea ever, that global surgery is so needed and global oncology is the next frontier, and they wanted to do everything they could to support me. There were a third of people who were interested in it, like, oh, that's an interesting idea, but weren't quite willing to put money up for it. And we're kind of, well, that's an interesting idea, but I don't think we're interested in supporting that. And then about a third of people thought I was crazy and that this was the a terrible idea and my career was gonna sink. And so I say that because I don't want people to get discouraged as you're going through these interviews and looking at jobs, and you're going to interact with a lot of people who just don't get it. And I think that this isn't unique to global health. It's common across most people who do research. Not everyone's going to get the idea, and it's kind of your job to really, key on things that are going to be impactful, and then to learn to communicate, maybe better than me. Maybe your numbers won't be broken by thirds, but you'll have half people think it's a really great idea. You communicate that impact, right? You need to get your elevator speech together, really be, ready to explain what you're doing, why you're doing it, why that's important, and how you're going to get there, all in, within the time it takes to go up 6 floors on an elevator. So when I was interviewing for jobs, I made sure to have kind of my plan. And people talk about your 3 and your 5 year plan, and it's good to do that in several iterations. One is the big picture, like where do you want to be in 3 years? Do you want to be at this institution doing this? The next is very granular. what exactly do you want to have done? I want to have 20 papers published in 3 years. I want to have, I want to be on three committees. I want to be, the sub chair of my internal, hepatobiliary or whatever, right? You need to, have those kind of big ideas and the umbrella of where you want to head, but also get granular because, in the business world, they talk about this a lot, these key performance indexes or KPIs. Your bosses kind of want those. And we never talk about that in med school or residency, but it's really important to say, like, not only am I going to get X, Y, and Z, these finite things done for you, this is how I'm going to get there. Now, I would encourage you, especially for global efforts, to make it very academic, but also realistic. You can't come in there and go, I'm going to cure liver cancer in sub-Saharan Africa. It's just, that's a great idea, but it's not something that a normal person can kind of wrap their hand around. You want to make it realistic, like, okay, we're going to build an academic program, and we're going to try and do these three things in 5 years, and it's going to produce this in academic in academic currency, right? Like this many papers, this many grants, this many things. I think if you come in with that idea, you're able to make global health a lot more rigorous, a lot more academic. I mean, that the bias against global health and academics is that we're not like real researchers, and we don't it's a lot harder to judge us. We'll talk about that a little bit later, but you need to kind of hold yourselves to the same standards that a biochemist is holding themselves to, where they're going to say, I'm opening a lab, I'm getting these experiments off the ground, I'm doing this and this and this, so that you're speaking the same language as these chairs and people hiring you, so they can understand that. So you're going to boil that whole thing down into a one-page cover letter, okay? And then you're going to send that cover letter around. I encourage you, as you're looking for jobs, to really put a lot of effort into that cover letter. 20, 30, 40 iterations of this thing. And you're going to skew it slightly differently for each institution that you're sending it to, because each institution is going to have different resources that you're going to want to comment on, how you're going to take advantage of. But in general, the theme should be the same throughout. But again, you need to be able to really communicate this vision in a realistic fashion to people who, frankly, don't understand, the whole global health mindset. Um, in terms of like where you end up, I was given the advice that, there's three things you're looking at when you're looking for a job. There's practice, like your clinical practice. There's the location, where you're living, and then there's the research support, right? And of those three, you get to pick two. Okay, I was lucky enough. Actually, in all honesty, when I started at UC Davis, the practice was not my ideal. The job they had here was melanoma and gastric surgery. I wanted to be a hepatobiliary surgeon, but the location was good for my family, and the research was, perfect. My boss came in with a lot of support, both financially, but also just in general, supporting me through applications and making sure I was promoted to different committees and all these things, so I could get my name in global health here at the university. And fortunately for me, my practice changed over time. Certain different people left, and there were different needs for the institution, and so I was able to migrate my practice. So ended up getting all three. But I want you to don't look at me and say, oh, like he got that, I should be able to get that. Look at me and say, okay, he took two and got lucky, and maybe you can get lucky as well. Um, You'll find that, especially with academic centers, negotiating your contract is a lot less about salary. A lot of these salaries are just kind of, they're benchmarked against the national averages, but you can negotiate support. And so I encourage you to do that. And the advice I got at MD Anderson was just to ask for everything. Just keep asking for things. And, the worst they can say is no. And if they say no, you got everything you could. And if they keep giving it to you, then you keep asking for things. And that you know, conception that, oh, I don't want to like seem greedy and I don't want to like over ask. There's some truth to that, right? You can't ask for the world, right? You can't ask for everything, but almost. I asked for a package that I thought would be a really good foundation for building what I was intending to build. I was realistic about it. I had, a budget built out for, I'm going to use this money in this way. I'm going to use this money in this way. I'm going to do it over this timeline, so that, it's very, again, tangible, and people can wrap their hands around it. But I didn't stop asking for things. And in a way, it's a good look that you're ambitious, but you also have a plan to get there. And if they support you, it's money well spent. And a lot of these programs, every these financial problems that the U.S. can wax and wane. But when people have money to spend, they want to spend it in meaningful ways. And so if you give them a meaningful way to do it, they're usually more than happy to support you. I was lucky in that, I had a chair that wanted to start a global surgery program, so I was able to just kind of get there and up and running. It's much more typical, like Nabil and my other friends who do global oncology work, to start slow. So they come in, maybe they have 50% protected time, but they're expected to be doing domestic research on outcomes or whatever, and then they slowly shift it over to global health. And I think that's a model, again, that I think you can think about building into your own practice, and that, maybe your 3 to 5 year plan is, okay, I'm going to start doing my outcomes database research and getting on committees and helping, build the practice at my institution. But by 5 years, I have this stepwise progression to moving these projects into the global arena. I think that's a lot more common and, a little bit easier to palate for some chairs who maybe don't like, maybe are interested in global health. They're in that middle third, but don't quite, think it's the best idea in the world yet. Um, and then the last thing I'll say about kind of preparing for your job is understand that you are going to be in two or more places at once at all times. I don't think I grasp that as a trainee, where, on my calendar, every single meeting is conflicting with another. Now, this gets worse for global health because, you obviously want to be out at your global health research sites. But there's some good advice I got, that if you prove to your partners that they can get on without you, they'll get on without you. Okay, so meaning, like, if I can show that my surgical partners don't need me around, that it's fine for me to be in Africa, they're gonna fire me. They've shown that they don't need me here. So what I've done is I've taken a lot of effort to make it seem like I'm always around. And then part of that is I'm answering emails in the middle of the night when I'm at research sites. My phone's always on. I'm always available. I'm making these trips short so that I can, be gone before anyone notices I'm gone. It's really important to kind of carry that presence, especially in surgery. And especially in surgical oncology, where we have a much more longitudinal relationship. We're kind of on call all the time. It's a little bit easier in things like ER and trauma, where you can, like, just be off. Like, you're not on shift, and so you're able to kind of disappear and no one will know. But I encourage you to start thinking about ways that you can do everything. So, just to touch on kind of academic success, as you're applying for jobs, people are evaluating you on your potential, right? And they want to make sure that you're going to come to their department and you're going to be successful and you're going to bring accolades back to the department, and you're going to go on to another job afterwards that, everyone gets to say is, I know him or her when, right? And so it's well documented that, especially in global surgery, it's a lot harder to be academically successful. And part of that is that academic success is measured on a different scale, right? It's not fair to measure someone who's building a whole program in another country and building those relationships and spending time doing the programmatic efforts, right? With the delay in publications against the person who all they need to do is log into MCDB, they pull a bunch of data, they rip it through with their biostatisticians, and they have a paper in a month, right? So there's a very different things, right? So I encourage you, though, to understand that we're being judged on that scale. And so to be as academic as you can. So, the small things count, the case reports, the societal grants, even if it's $15,000, yeah, it's not an R01, but those types of things matter. And so keep applying for those things. Try and hold yourself to the standard that the other researchers are being held to, even though it may be not, exactly the right metric for us. But I promise you, if you do that, they're able to, again, grasp what we do a little easier. Oh, like, okay, yeah, Cameron does global surgery and he's published this many papers, which is the same as, or more than a lot of these outcomes researchers. It helps justify them supporting these kinds of efforts that maybe they don't understand. The second thing I'll say is to understand the priorities at your institution. Okay. Like everybody has an institutional currency, right? So global health, what I'm interested in doing, which is like the liver cancer research and all of that, isn't something that the School of Medicine really cares about. And I say that not because they don't care about liver cancer, it's because their interest is getting their students into global surgery, right? And so understanding that, okay, I can make that connection between the students and global experiences or mentorship in global experiences is, my institutional currency. And so being able to leverage that, making sure not just that I'm not focusing on it per se, but I'm making sure to not forget it, right? That the reason that the medical school here values me is because I can help their medical students, not because I'm, helping abate, world liver cancer. Um, the other thing I'll say, or the next thing I'll say is make sure that, global health uh, let me say it's rare to make global health your entire career, right? So even for me, where I have 50% of my time dedicated to global health, I'm still a pancreas and hepatobiliary surgeon, right? And so I try to link those two in terms of like what research I do, but I'm also making sure that global health is a component of my overall career. My overall career includes other things. So for instance, for me, I'm the head of the pancreas surgery group here. I am the on the executive committee for the UC Pancreatic Research Consortium. I'm the service line champion for the HPB NISQIP committee here. I'm doing all these other things that don't really have much to do with global health, but they have to do with pancreas. And if my entire career is around, being a hepatobiliary surgeon, and most of that I hope is in low resource areas in sub-Saharan Africa, I'm still a hepatobiliary surgeon in California, and so that's my career. And so make sure that you're not forgetting about the rest of things, I guess. I have my fingers in a lot of different pots, and part of that is to make me relevant to a lot of different people, so that they can't just get rid of me. But also, we're moving forward research here that maybe will impact research abroad in the future. One of the things that I've developed is the early diagnosis clinic for pancreas cancer. Those types of resources and infrastructure are transferable to other places. And so, that could be the beginning of another venture in cancer care in sub-Saharan Africa, but it started here. And it also gives, like, again, more institutional currency to myself, in that they're looking at me, oh, not only does he do global health, but he's also got this other thing going on that we really value and brings in money and patients to our institution. And so with that, like,
So, Cameron, there's about 5 minutes left, so
oh,
really appreciate you sharing. And if it's okay, I want to make sure that our trainees can email you if they
yeah.
have, any questions in the future. And I just want to make sure that, we have, let's see, yeah, about 5 minutes remaining. So just wanted to invite, and then Julie, these slides will be available, right, for the trainees? And wanted to invite our
Yes.
trainees to ask away. Uh, I found this really, really inspiring and very informative and helpful. So um, while Dr. Gaskell is here, if you have any questions, please unmute yourself or type it in the chat. So really appreciate your time. Um, any questions? Um, In the meantime, if you have any questions as you reflect on this talk, feel free to reach out to Dr. Gaskell. Um, so I guess, in terms of this is like a meta question in terms of what is currently happening in NIH and NSF and other academic, like in general, like attack on our academic freedom and global research and health disparities research. And then I know that you mentioned KO1 pending. Do you have any like forward thinking like perspectives on how do we navigate this challenging time? I know that, on May 1st there was a notice from NIH about like not allowing foreign component in awards that are, international. So just wanted to, it's a pretty macro question.
Yeah, I mean, we're all freaking out. I don't know. I think so. I had a long talk with our cancer center director about kind of just in general the funding landscape.
Yeah.
And he, in his optimism, kind of, will adjust. And so we'll
Mm,
write new ways, new ways of writing grants and, with new angles to them that allow us to do the work we want to do, but, don't necessarily, focus it on that.
mm,
You know, the other thing is looking at other revenue streams. So yeah, I mean
hmm
the
hmm
NIH, like there's a lot of barriers right now to that. And my the K award I wrote is for Tanzania and
hmm
very unsure whether it's even going to be read, whether that study section
hmm
is even going to meet. And we're holding out hope and uh yeah, I mean I think it's just so illogical to not understand how global health affects the US, even with a US centric viewpoint,
Yeah.
given COVID and everything we just went through.
Right.
Um, but here we are. That being said, so there, there's a lot of foundational things. I think
hmm
industry is starting to step up a little more. We have, in academics, we generally shy away from industry sponsorship because there's, some conflict of interest. I've had a lot of conversations recently about getting them more involved and kind of having them from a kind of a business standpoint. This is my wife does my 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 wife does corporate responsibility. So one of the things I was going to talk about is how the importance of family and how like to be supported by your family in
Yeah.
global health is like a mandatory thing. Um, so, businesses have found that if they do good things in the world, that their stock goes up. Um,
hmm
and so, starting to lean on the industry partners and even like position them as, hey, the NIH is not able to support this, so we're going to step in and we're going to support advancements in global care, even though like there may not be a market for them to earn money in. Uh,
hmm
is I think that's a realistic viewpoint, and we're starting to have those conversations with big companies, and they're starting to kind of come around to that idea that they could fill that gap, at least in the interim, while we figure out the NIH. But we'll just have to see. Um, it's tough, and then of course there's private foundations and
hmm
just fundraising, and so pancreatic cancer research, a lot of that is funded by donors and
Right.
walkathons and all sorts of things like that. And so we need to get a little bit more crafty about how we go about finding money to do this stuff. I will say that one thing, that we have that's that puts us in a better situation than a lot of research is, we can do global oncology or global surgery research pretty cheaply on the scheme
hmm
of things, right?
hmm
The packages that translational researchers need versus the packages we need are much different. And so I think it also encourages us as global researchers to be a little more, lean and really stretch those dollars and make these projects impactful. And that's we're all trying to kind of figure out how to do that best.
Yeah. That's great. Well, thank you so much. Though we're right at 8 o'clock, but really appreciate your perspectives. And I think the question that Richard asked was essentially what you just shared in terms of your perspective on the future of global health. And I think one last comment is like you've done such a wonderful job in terms of elevating capacity in your low and middle income country partners and institutions. So one strategy is for them to be the prime applicant, like for example, NIH, the foreign component, if you're the prime sponsor, they're still at this point allowing them to do that. So like K43's Career Development Award from low and middle income country scholars, that's still supposedly ongoing. So
Yeah,
I
for
think we
now.
just have to be creative and
Yeah.
persevere.
The other thing is we're very like US centric,
Right.
like we're all worried about the end. There's a lot of other countries with funding mechanisms. I mean,
Yeah.
Germany is the second highest global health funder. And so we're starting to look at other places to find funding. Um, I think is, there's a lot of other people interested in doing this type of work. And so we can start looking external too.
Great. All right. So we are over time, but again, thank you so much. And Julie, any updates or administrative news that the trainees need to hear?
No, nothing at this time.
Okay, great.
Thank you all.
Thank you all and take care and have a good rest of your evening and morning.
Thank you, you too, Jay.
Bye.
Thanks, Dr. Gaskill.
Thank you.